Hello from Hong Kong, where it's just gone 10 p.m. and welcome to the first of three launch events of the Global Health 50/50 report called Flying Gender Blind. What does this mean for health? And what does it really mean for health, for everybody, for equity, especially at this time of COVID-19, but also well beyond that? I'm James Chow, as I said, joining from Hong Kong, host of the China Current, and also World Health Organization Goodwill Ambassador for SDGs and Health. I'm particularly honored to be here in my capacity as a member of the Global Health 50/50 Advisory Council. A quick note to everybody around the world joining us. We have hundreds of people who are pre-registered and many more joining us live stream on YouTube. This session is being recorded for posterity and hopefully for generations more to come. Today, we're going to be exploring, unpacking, and delving into the reasons why, despite all the evidence and advocacy around the profound relationship between gender and health, gender blindness continues to afflict so much of our treasured global health family. This week, amidst a devastating global pandemic, we celebrate, of course, International Women's Day, and in the midst of this glorious Women's History Month. It's a day of celebration, it's a day of honor and hope, and it's also a sobering reminder that progress towards gender equality is neither inevitable nor is it irreversible. COVID-19, more than it ever has before, has really brought home that we all live in gendered societies and that this impacts our health in dynamic and complex ways. So I'm really honored to be here today, joined by an army of people who know everything that we need to know, I think, our great panelists, and of course, all of you at home. We're going to discuss how collectively we're going to push leaders, organizations, and ourselves, importantly, to embed the struggle for gender equality across our work and in every facet of our life in the air that we breathe. Let's start off with Professor Sarah Hawkes, who is the co-director of Global Health 50/50. She's also Professor of Global Public Health at the University College London. And right beside her, in harmony, balance, and every aspect of gender equality, is Professor Kemp Buse, her fellow co-director of GH 50/50. He's also director of Healthier Societies at the George Institute for Global Health. On one part of your screen, you'll be able to see Anuradha Gupta, who is the Deputy CEO of Gavi, the Vaccine Alliance, an organization that I think so many of us, Anuradha, is looking to with great hope and great gratitude for everything that you've done for us to ensure that vaccines really are a possibility. Catherine Hay, Deputy Director for Gender Equality at the Bill and Melinda Gates Foundation. She is, of course, over in Seattle. And then we're going to go from Cambridge, Geneva, Seattle, bringing us all the way to Delhi for Ravi Verma, who is the Director of the International Center for Research on Women Asia and my fellow GH 50/50 advisor. Today's going to be really fun. We've got 60 minutes of interactive discussion, interactive with the panelists and interactive with you. So you can use your comments feature on the platform you're using to send in your questions now, and I'll do my best to try and get to them. If we don't, we'll clearly have a clear mapping of what the opinions are as this live conversation continues. We're going to have a first round of questions with our panelists. Then we're going to go to you at home, at work, wherever you are. And then we're going to go back to our panelists again. But first, we are going to go to Professor Sarah Hawkes. And before that, we're going to go to a live poll because we'd love to know for a start where you are. So we can bring up the poll on the screen now. You should be able to see a question popping up for you to answer. And it is this. It's a quick poll to see where you're joining us from, the audience demographics. Question one there is, which region are you joining us from? So Europe, North America, Sub-Saharan Africa, Middle East, North Africa, Asia, Latin America, and the Caribbean, and Oceania. I hope that we've got you all included over there. And then just to see where you come into the picture, what is your role? What capacity does your interest bring you in from today? Are you, for example, a head of an organization, a representative of senior management, a staffer, independent, student, or other? And also, is your organization included in the 2021 report? Is a yes, no, or a don't know? So we're going to give you a couple of seconds to get through that. And as you do, I'll just gently remind you that on social media, you can hashtag us. so that everybody else who's not here can feel a part of this. The hashtags we're using are our regular one, which is hashtag GH5050. And the second one for this launch event is hashtag flying blind. So the three questions again: number one, which region are you in? Number two, what is your role? Number three, is your organization included in the report that was released on International Women's Day? I'm not sure if I'll be able to see the results. Let me wait and see. Does it come up for me? Oh, yes, here it goes. I'm not sure if you can see it, so excuse me if I'm breaking down the obvious for you, but in case you can't see it, 65% of us are in Europe, 17% are in North America. It's on the earlier side there. 9% are in sub-Saharan Africa, which is interesting because, of course, a lot of the health burdens do lie in that part of the world. Middle East and North Africa, 2%. Asia, 7%, and that's not me because I can't vote. No one from Latin America and the Caribbean, no one from Oceania. So we've got by far a big proportion of people in Europe. I think that's quite interesting. As we go down to the roles, heads of organization, 13%, senior management, 17%. So together, that's about a third of the people here. Employee, another third at just under 31%. Independent, 13%. Students, I think that's great because we need to hand off to another generation of health leaders, and other is 6%. I think some of my friends are the other over here. Is your organization included in this report? Yes, 26%, no, 39%, don't know, just over 1/3 of you. So that's who you are. Thank you very much for being with us. And thank you also to Professor Sarah Hawkes, who's going to take over things now and present us with some of the key findings that you can find in this extraordinary report that's been put together by the GH50 Collective and co-led by Kemp Buse, who you can see behind and beside Sarah Hawkes. Sarah, could you take it away, please?
With pleasure, James. Thank you very much for that wonderful introduction, and also for a fantastic summary of what you, the people on this call and anybody viewing this video subsequently will be able to look at on the web. If they go to our website, they will be able to look at all of the details of the report in detail. But what I'm going to present to you in the next few minutes is a very small snapshot to put some of those data points that you mentioned, James, into the domain that hopefully our panelists will then be able to respond to. So Sonia, if I could have the next slide, please. So as you might have gathered by now, Global Health 5050 produces an annual report looking at the status of gender equality in the global health sector by reviewing 200 organizations across 4 interconnected domains. So one domain is, do those organizations make a commitment to gender equality? Do they actually put out onto the web a statement that says, we believe and support gender equality? That's part of our value system. And then we assess what organizations are actually doing in terms of policies for the people working inside those organizations, career structures, equal opportunity for everybody to progress in their career pathway. We then look at some of those outcomes, who actually leads organizations, what do they get paid? And if I could have the next, if you could click, please, Sonia. What you'll see here is that what I'm going to focus on in the next couple of minutes is how those organizations actually deliver on a gender responsive approach to the policies and programs that they deliver on externally to the people that they are trying to reach through their own activities. And whilst we present these in the report as separate, siloed sections of the report, very much the report and what I'm about to show you is our theory of change behind all of this data is that these are all related to each other. So although I'm about to focus on gender and the health responsiveness of organizations, we think that that is linked to these other features of what organizations look like. So if I could have the next slide, please, Sonia. So what we've seen in terms of commitment to equality is that organizations have really learned to talk the talk over the 4 years that we've been measuring the same set of core variables. There's been an increase from 55% to 79% of organizations in 2020 had an overt commitment to gender equality on their website. Next slide, please. What we also have seen is a very wonderful commitment and responsiveness to gender equality in the policies and programs that organizations tell us about, that we can see on their websites. And so we assess the policies and practices and programs of organizations using the WHO Gender Responsiveness Scale, which is actually a 5-point scale. You only see 4 of the points here because the worst part of the scale is gender unequal. In other words, an organization would do something that actually makes gender equality worse. But what we've seen, if you just focus your attention on the green bubbles, we have seen that even between 2019 and 2020, there has been a 10% increase in the number of organizations assessed as being gender responsive in their activities. Next slide, please. Okay, so that's what we see when we look on the web. This is the talking the talk part, but what about actually walking the talk? What are they actually doing in practice? So next slide, please. We've seen one of the things that COVID over the past 12 months has really shown us is that sex and gender absolutely matter to health outcomes. There's a whole other part of the GH 50/50 set of activities focused on gender, sex and COVID. I'm not going to go into that now, but it really, really illustrates to everybody that sex and gender are an integral part of what drives health outcomes for everybody in the population. Next slide, please. So what we've done across the 200 organizations is look at how gender responsive have their COVID policies and programs actually been. We looked across 5 different domains of the COVID responses that WHO recommends all organizations in the health sector should be delivering on if they are responding to COVID. And you can see that the variety of activities that organizations were undertaking. We found about 350 activities across 140 organizations. And if I could go to the next slide, please, Sonia. This is where we really see is there any evidence of walking the talk? When the rubber hits the road in a pandemic, how gender responsive are the activities of the organizations working on the pandemic? And what we saw is across the board, 80% of the time, organizations delivered interventions, policies, programs that were completely gender blind, didn't take gender into account at all. Next slide, please. So the summary of that is that we can see that 80% of these 200 organizations are talking the gender talk, but only 20% are actually delivering a gender responsive walk in the time of COVID. Next slide, please. When they do have gender responsiveness or not even, some organizations are deciding who should benefit from their activities in the time of COVID. And what we've seen from the organizations that actually stated the populations they were trying to reach, the vast majority of those organizations, represented here by the purple squares, are trying to reach women and girls. A very, very small number of organizations are trying to reach boys and men. Something that in previous years' reports we have seen is replicated across the global health sphere, that the vast majority of activities in the global health sector and the global health sphere, if they are directed at a part of the population, It's generally women and girls. It's very rarely across the population to include men, boys, people with transgender or non-binary identities. Next slide, please. And finally, this is kind of the easiest part of what a sex and gender responsive organization could and should be doing, which is sex disaggregating their data. And for us, this is the one data point that has not shifted at all across the 4 years of the report. Only less than 40% of organizations are sex disaggregating their programmatic data. And I think that is the end of my data points. Thank you very much, James. I'm handing back to you.
Thank you very much, Sarah. So some thoughts for us to ponder as we carry this conversation forward. Our societies are gender unequal, as Professor Hawkes showed us there. So it should be no surprise that COVID-19 affects people of different genders unequally. Yet we've also just heard from her that when Global Health 50/50 delved into the activities of leading global health organizations, they found that 80% were gender blind. Now I'd like to turn back to all of you watching us, and I want to ask you a couple of questions coming up on your screen again. The first question is this: do you think that sex and gender have mattered to health outcomes during this pandemic? I'm also going to ask you this: the global health sector understands the importance of sex and gender to health, yes, no, or don't know. And finally, the organizations you work at is doing enough to include gender in their core health programs. So 3 questions there for you to address. And don't worry, as far as I know, all of this is anonymous. So please put in what you really, really think, because that's going to very helpfully allow us to map out what your thoughts are. So do sex and gender matter to health outcomes during this pandemic? Do you think the global health sector understands the importance of sex and gender to health? And do you think the organization you work at is doing enough to include gender in their core health programs? Well, are the results coming up on your screen now? And here they are. In response to the first one, 89% of you do say that sex and gender matter to health outcomes during this pandemic, which is promising, because if we'd said no or don't know, the majority of us, I think that would be a real issue. The global health sector understands the importance of sex and gender to health. An incredible 52% of you said no. 40% almost said yes. 9% said don't know. That's very interesting. And the organization you work at is doing enough to include gender in their health programs. We're going to hold that in the head right now as we turn to the first of our guests, and that's Ravi Verma, who is the director of the International Center for Research on Women in Asia. Ravi's over in New Delhi, but we're blessed to have you with us right now on Zoom, Ravi. Ravi, we heard from Sarah that just 4 in 10 organizations sex disaggregate their programmatic data. What is the power of this data, and what have you learned in your work tracking sex disaggregated data on COVID-19?
Thank you, James, and thank you, Sarah and Ken, for having us here, having me here on this panel. It has been quite a journey working on the Global Health 50/50 report and later on data tracker. So past 8 months or so, we have been tracking COVID-19 data from over 190 countries, and they have truly revealed a lot of insights that should be taken note of by the global health communities. We've seen that of all the countries that report the data on the clinical continuum, from the testing to the to the ones who get hospitalized or get into ICU or health professional health frontline data, and death, sex desegregated data, whatever minimum we have, it really shows that biology and the gender is at play. What we find is that if you take the testing, there are more men who get tested. There are more men, and infection, the cases is almost equal between men and women. But the moment you move up on that continuum, you begin to see the differences where more men get hospitalized, there's more reporting, more countries report of men dying. And the differences between men and women, in fact, gets situated within the context from where the data is gathered. It is the larger gender equal society, or the larger context of gender equality within which these men and women are situated, the extent to which they can have exposure to they have exposure because of gender norms really makes a difference. So sex is only a part of the story. The larger part of the story that does not get really captured in this data, and the sad part is that this is an incomplete data. That a lot of the countries are not really presenting this data. So a lot of sorry.
Ravi, actually, can I just jump in there? Because you just said something which was very important. You've identified the gaps, the missing parts of this. So can I very quickly ask you, in a couple of sentences, what are the consequences when you don't capture everything, when you've got missing certain populations from this data because gender sometimes gets too narrowly defined?
Clearly, you miss out on the pathways of the vulnerabilities. You don't get to know as to what are the drivers and who are the people that we need to reach out. For example, as Sarah said in her presentation, the gender binaries really bind us into only looking at rigid categories, and we miss out a whole lot of the other people and the hidden populations whom we have anyway not reaching. So universal health coverage or the SDG framework really has, the purposes get defeated if you don't even get the basic sex segregated data and the larger context within which these things are playing out. Somewhere men are high and somewhere women are high. Yeah, James.
Thanks very much, Ravi. I want to take your thread and link it over to Catherine Hay, the Bill and Melinda Gates Foundation. Catherine, good morning. I think it's 6:25 a.m. in Seattle where you are. So we're really grateful that you got up at 5 something, I think, just to be with us, but also to offer and extend your expertise in this area. Let's go in with this perhaps. What have you seen are the barriers to recognizing the importance of addressing gender to improve the health of people? When you think about that, do you think about lack of evidence, perhaps lack of political will? Is it a reflection of who is making those decisions, or is it something completely else?
Thank you, James. Thanks for having me on the panel. I think you're really sort of getting to the heart of the issue. Why are we still talking about this? It's 25 years after Beijing. Why are we still struggling to get gender on the agenda? Why are we seeing the kind of numbers and data that Sarah just presented? And I've been working in public health organizations for 20 years. On one level, to some extent, I think that there's a lot of people in the public health space who feel that there's a lot of simple, and I use that, these are not simple problems, but there's a lot of problems that remain to be solved, such as, children dying of vaccine preventable illnesses that we need to focus on in global health. And that for those things, yes, there's sort of challenging gender norms and issues, but we don't need to focus on those things right now. We just need to kind of get those vaccines into the arms of those children. And we're not denying that there's these issues, but please, people, work on them over there. We're going to be sort of working on these difficult injustices and tragedies and sort of be focusing there. At the same time, I think everybody who works in global health, especially global health delivery, knows that gender and gender inequalities shape and determine every health outcome that we're trying to achieve, period. That all of our health goals will not be achieved, including all the vaccination goals that I just described, without closing those gender gaps and barriers. And so there's a dissonance between my first and second statement, but human beings are complex and they can hold dissonant statements. at the same time, and I think many do. So if we start from my second statement then, that we do ultimately recognize as health professionals, as public health professionals within our organizations, and we have for several decades, that gender inequities are fundamental in addressing them to achieving our health outcomes. We get to your question of why are we still struggling to get it on the agenda in a fundamental way and not just as a sort of small side agenda. And you ask, is it a lack of evidence? And that's, a really interesting question to me, because I hear that a lot, and I work a lot and have worked a lot on evidence generation, and I love research and studies and getting more data. And it's been a huge part of sort of the work that I've tried to do. And I've been part of reviews that have tried to look at questions like, do more gender intentional, gender transformative efforts deliver better health outcomes? And spoiler alert, there's not a whole lot of studies where you can actually have those comparisons, because there's not necessarily a whole lot of gender transformational approaches that you can compare to other approaches. We see it also in terms of women in leadership. It's not enough to simply say, well, gee, wouldn't it be fair if there was, and if there was parity in terms of women in leadership or representation from the global south in leadership. We also have to say, and would they lead better? Would it lead to better health outcomes? Let's test that. And, turns out it does, that you have more diversity in leadership, you have better decisions, etc. But I think that these sort of seemingly neutral calls for more evidence, it seems neutral on the surface. Like, let's just get more evidence that having this inclusion or diversity of these gender transformative approaches, if we were less racist or less sexist or less colonial, would we get better health outcomes? When I put it like that, it doesn't maybe sound quite as neutral. And so I think that gets us really to the heart of the matter. And the reason that, why we still struggle, even after so many years of recognizing that gender is this fundamental factor that predetermines and shapes health system and outcomes. And I think, James, that it's really at the heart, it's the pervasiveness of structural biases and power imbalances. And so you fundamentally have these biases, these structural biases that influence who has a seat at the table. And it's fundamentally an issue of power and voice. And we see individuals trying to change things. I see wonderful individuals saying, I have power, I am a male, I work at a northern institution, I'm going to give first authorship to a woman in the global south, I'm going to give up my seat at the panel. And these things are great, but fundamentally we need organizations to change, and organizations are deeply organized around traditional, elite, often northern, male-dominated values, relationship, ways of working. It's very difficult for individuals to change them, no matter how dedicated they are. And institutions have really rarely invested in the kind of deep changes in culture, data transparency, power sharing, inclusion, those kind of fundamental changes to change institutional DNA. And we saw it with gender mainstreaming, where it started out as a political process and it became sort of a strategy, a set of strategies. And I think with the new sort of push around DEI, that's really, I'm seeing it so strongly here in the US, I feel like it's we're at the similar crossroads. Will we take that path of having this be a fundamentally political, potentially disruptive moment, or will it become a set of strategies?
Well, that's great, Catherine. I mean, I could really hear what you're saying about the gestures and the good intentions that people have, moderators and panelists, especially in trying to do that. But I think a lot of that is actually cosmetic, that the transformation needs to be rooted in the heart of the organization and then springs forth from there. So let's now ask Anuradha Gupta, who is the #2 at Gavi, the Vaccine Alliance based over in Geneva. Gavi, of course, has been front and center, as we said, as has organizations like the Gates Foundation and Mr. and Mrs. Gates in pushing for equity to be central to the global COVID response. Yet we heard from Sarah, and I think this is very important, what she said here was that the report found 90% of activities around vaccine development and rollout activities were gender blind. Has that been your experience, Anuradha?
Yes, absolutely. And I just do want to build on what Catherine said. And I think we see persistent challenges on equity because equity is political. People are being left behind, not by accident, but because the most marginalized are often those who have no voice, visibility, or power, or even a steadfast champion to stand up for their rights. But I also feel that a lot of times we are not able to get equity right because people who are driving these conversations and driving decisions do not have any understanding of what the lived experiences of women and some of these marginalized populations are. And if I could share an example with you, James, about the time when I was leading polio program in India. And that was the time when the world was despairing about India's poor performance on polio, and because we accounted for half of the global polio burden. And, people thought we would not be able to do it. And then, I took charge of that program. And the first thing that struck me was that the program was just focused on coverage. How many children are we covering, right? Nobody was focused on how many children are we missing. And that's what I brought to the table. And I said, I don't care whether we are reaching 90% or 95% children, because the same children were being reached in every successive round of polio immunization. But let's just focus on those households where children are being missed. And those were the populations that were living in abject, extreme poverty and were not visible to anybody. And that's what actually gave us dramatic results in just a year's time. And now during COVID-19, we again found that in most Gavi-supported countries, outreach immunization services that were meant to reach vulnerable populations were the hardest hit during the pandemic. As health workforce got diverted for COVID response, the simplest thing for everybody was to deprioritize services for the poor because they just simply lacked any ability to protest. So the consequences that the number of zero-dose children who do not receive even a single dose of vaccines and are therefore at high risk of dying because of vaccine-preventable diseases is set to increase manifold. And coming to the issue of data, if we do not look at data carefully, so one is data is sexist. So a lot of times we don't have enough data on women in particular, but wherever we have data, we are also not looking at that carefully to inform our policies. For example, when we started to dig deeper into this whole mystery of zero-dose children, then we realized that 1 in 8 children, does not receive any shot at all. And 50% of child deaths are concentrated among these children. So this is a wake-up call, that these are poor communities that are suffering from multiple deprivations, can become epicenters of new disease outbreaks, which can spread really fast. And I think it is really time for us to bring to the table those people who have a much better understanding of equity and how to get the right data to understand this whole puzzle of equity, and then use that data in order to have policies and programs that are very relevant for those people who are currently excluded.
Anuradha, you hit the word over there, the word that we keep on coming back to time and again, because you can talk about gender and you can talk about health, but what it boils down to is equity. How do we create a free and fair world where each of us has the potential and that potential is unleashed to live the best life that we really can? And I always say this, not best life as in the Instagram best life sense, but really a meaningful, purpose-driven, substantive life. So my next question to you would be this. I mean, what have you learned? I mean, if you think about the enormity of the waste of the last year alone, this tragedy that has punched us in every part of our body, and the grief and the mourning that we've been thrown into, what have we learned about the issues of equity, whether it be through the lens of gender and beyond, that so often fall off the agenda in a time of crisis? And Anuradha, if you look into your skill set, what are the consequences that we should anticipate? Anuradha, just wondering if you caught me over there, right?
Yes,
Yeah,
I can hear you, but you just faded off for a moment. So can you repeat the last question, the bit of the question that you wanted to ask me?
I mean, you as a senior leader in the world, when we look at all of these issues around equity, what have you yourself learned about equity, whether it be through gender or otherwise, that so often falls off in times of crises? What are the consequences that we're going to have to handle?
So first of all, the consequences of neglecting equity are going to be very serious. As I said, we are now standing at such an important inflection point where hard-won gains of several decades are really threatened. When I look at child mortality rates, I'm really scared, because we now know that 1 million more children could die within 6 months because of disruption of services for the poor. And for the first time in several decades, the number of extremely poor people is set to rise. So about 150 million people might be pushed into extreme poverty by 2021. So this is scary. And what is really even more scary is that women and children often bear the brunt, as we are seeing on a daily basis. More girls are falling out of school, becoming victims of the shadow pandemic, sexual violence, domestic abuse. Millions of women have lost their livelihoods, do not have access to essential services such as antenatal care and skilled birth attendance. And I really want to make this point, James, that we really need to get more women in the room, at the table, and really driving decision making, because I think these are issues that require, a very deep understanding of the human dimensions of the impact of the pandemic. And we have seen in different capacities, women have been able to weigh not just the economic or health implications of COVID-19, but have also brought a human-centric attitude and empathy to solving some of these problems.
Great. Let us now go to a quick round of questions from everybody, which is the next poll. Having heard from our speakers about the challenges in keeping gender on the agenda, and yet how gender-responsive programs could deliver better health for more people, my first question to you in this poll is, do you have a clear idea of what gender-responsive programs would look like in relation to the work that you do? And very quickly jump onto this next question. Do you think they would, or have you seen that they improve outcomes in the work that you do? So 2 simple questions, yes, no, don't know, fire them away. And we're going to bring up those responses as soon as you do that. And as a heads up, if you've got questions in the audience, please filter them through. We can see them coming up on our screen, and I'm going to tackle those next and throw those to any of our panelists. I'd love Professor Hawkes and Professor Bewes to join the 3 other panelists for this segment as well. So our polls on gender responsive programs, I think our responses should be coming in very shortly. And there you go. Yes, 60%, no, 24%, don't know, 16% to the question, do you have a clear idea? And then do you think it would necessarily improve outcomes in the work that you do? Well, yes, very clearly 84%, 4%, no, 12%, don't know. Sarah, very quickly, just in a nutshell, does any of that surprise you, or what should we be looking in terms of unpacking?
It does not surprise me enormously, James, and I think it actually was that Catherine touched on this. And I'm sure other panelists would agree that not enough attention has been paid to moving from the notion of gender as something, gender equality as something that is a value-driven norm within society, to showing what works to achieve gender equality. That, we might all agree that gender equality is something that every society should be aspiring to. At least I hope everybody on this call agrees, listening in. But how you actually get there, I think really what we're seeing is that there really has not been enough attention paid to that question.
Shall we jump in now to the audience questions? There are quite a few, and they're from a very great many of you, great in terms of the experience that you bring in, thanks to people like Dr. Morna Cannell, who's from the University of Cape Town, Zara Zinali, who is a physician based over in Berlin. And we've also got Ming Liu, who is not engaged in this work, but is a writer at the Financial Times and the New York Times. As we go around, let's look at this question first. To any of you, jump in and let's be quick on this one. After so many years of arguing for sex disaggregated data, why has it been so difficult for organizations to collect that data, first of all? To any of you, a quick response to that.
Yeah, so James, if I could come in, Gavi is a very good example where we started to insist on sex disaggregated data early on. And, that is what helped us establish that there isn't any significant difference in terms of access to immunization between boys and girls. And yet, as we dig deeper into this data country by country, we realize that within countries, we could have certain communities and geographies where we still have sex-related disparities. But, one thing that we heard over and over again was this whole notion about putting additional burden on countries for no data. So I know that we have been under enormous pressure to actually discontinue sex disaggregated data collection on immunization. So I guess, this tension between the importance of sex disaggregated data and the effort that is required to gather that is something that we need to tease out. It is not necessarily a very difficult or complex process, but I think it's a perception that collection of sex disaggregated data is difficult. And probably that has something to do with this whole notion of how much of premium or value we place on certain things. And that is why when Melinda said data is sexist. So if we don't value gender perspectives, then of course we don't value collecting data related to gender and women.
Let's quickly go. Please,
could I just build on that just very quickly? I completely agree with Anuradha, and I would say that the other issue as well, on top of collection and the costs and making sure that head of household, for example, often male, so you're getting different types of data, but even when you collect and you have sex disaggregated data, the other issue is the analysis. So if nobody actually analyzes that data and looks at, well, who's affected, looks at cuts in terms of gender, race, etc., you may have the data, but if you're not analyzing it for those patterns, we're not illuminating who's being left out, which children aren't being immunized, for example, who's being missed. So it's also an analytical question. And are we putting the resources into analyzing when we do have the sex disaggregated data as well? Thanks.
Well, I've got another question for any of you over here as well. Perhaps Ravi or Kent could touch on this one. Because we look at, actually, we look at this, Sarah. Sarah, this came in specifically for you. What, in your opinion, is the best way to move towards more gender transformative programs in global health? And what are some of the practical suggestions? In fact, anybody can respond to that.
James, I think if it's a question of how do we move to gender transformative, I think that this actually builds on what Anuradha and Catherine have just been saying. I think, to be absolutely clear, it's not a question of us not agreeing on the values. It's a question of having the clear evidence of effective pathways to achieve that change. And that, I think, is a question of political will. Because what we also all know is that even if we've got the evidence, that does not automatically then feed into policies and programs that are gender transformative. So this is about shifting mindsets as well as producing clear evidence of what works.
Just very quickly, Sarah, just in a couple of sentences, because we need to move on to the wrap up over here. Someone asked, could you elaborate on your comments that most activities in global health focus on women and girls, and they rarely include men, boys, transgender, binary individuals, non-conforming?
Yeah, I think that speaks to something that we have very much been putting forward in Global Health 50/50, which is that a lot of global health talks in very binary terms. And so what we've ended up with is a situation where we are, as a global health community, we're skipping over the notion of gender. What we're doing is creating binary silos, which I think at the end of the day does a disservice to everybody, recognizing that gender in and of itself is a relational construct. So women are unequal in relation to men. So unless we start to think about including everybody, we are unlikely to achieve the kind of goals that we've all agreed upon.
And I think this was part of the thinking behind the branding of Global Health 50/50, was that 50/50 was the look at the irony. We're not 50/50. And so the 50/50 was a way of presenting that to challenge all of us to say it's not 50/50, it's 360, and it's beautifully so as well. So thanks very much for creating and pushing us to see the reasoning behind that. Let's go very quickly to a last round of questions, and we ask you to put this in a minute or so. Let's go first to Ravi. I mean, Ravi, even with practical support and tools, gender being left off the agenda is often a political choice. We've seen that. How have you convinced those with power to prioritize these issues? And what lessons, Ravi, can others take away from that?
Well, thank you for asking me, because I think this, the concept of gender and situating this within the discourse of policy circle is a process. We know it's how complex even the concept is. The gender transformative, to say that we must move to gender transformative stage is easy than done. Every pillar of health system, every aspects of the health system, from clinic to the service delivery to the trainings, is all gendered. And I think use of collection and analysis of data, or collecting the sex disaggregated data, would not really matter much unless at every level this is mainstream. Mainstreaming is a very hackneyed kind of stereotypical term, but I think the idea of using data at the local level to plow it back into the system is the most difficult part. I think, where does the data come from and how that gets used in the local planning process and integration of different sectors in creating the larger ecosystem of transformation is what is needed. And I think it's beyond health. It's talking about convergence of different sectors and different mindsets. So the lesson, I think, what I have learned, and I think is that one needs to be ready for difficult conversations, for a conversation that is kind of a pushing back and negotiating. It's a negotiation at every stage. So my sense is that it's a long journey. We should all of us who are committed to this have a responsibility, must make sure that we don't miss the opportunity, whatever little window of opportunity we get in our conversations to situate this whole idea. So talking about power of data, we must really talk about that. But I think we should soon move beyond just the power of data, because it really pushes people back. It puts them into defenses. And therefore, I think personal journeys, the personal accounts, the fact that all those who are responsible for ensuring, they need to have a personal stake in this journey of gender transformation. I think that human aspects of the relational aspect that Sarah talked about needs to be operationalized. That needs to get into the language, which is missing. In fact, sometimes we become too technocrat even in data, in the articulation of data. And I think we need to move beyond that. A lot of social science and larger ecological and multi-sectoral, multi-level perspectives need to be a constant part of this discourse,
And therein is, I think, a lot of the answers: communication, understanding where our part is in it, and also our role as stakeholders. And it's not just the people watching and listening right now, many of whom are part of the global movement, but I think especially all the people outside of it, young people, older people, every person is a stakeholder, because this shapes our future and also our present. Catherine, may I come back to you also very quickly? What can funders do to support organizations and governments to develop health programs that take gender into account, that blend it right in?
Okay, absolutely. I know we don't have much time, so I'm just going to rhyme off 6 things without a lot of detail. So the first thing, we have to change ourselves. At the beginning, I talked about a lot of the barriers and challenges, but I'm ultimately optimistic. I'm seeing a lot of change. I'm seeing young people in our organizations trying to push for more diversity, more, power shifts. Power doesn't sort of cede itself lightly. So it's not necessarily going to be easy, but I'm seeing a lot of energy and I'm ultimately optimistic. So we need to change ourselves. And then I think we can really play a role in sort of filling data gaps and bringing better data to the table in partnership with governments and others. Donors fund a lot of research, and a lot of research is really gender biased and can be much more gender transformative and inclusive. So I think that's something we can do. I have a lot of hope in terms of the workplace and the workforce and the public health workforce itself, which is a lot of women, a lot of community workers. And so I think that in our work with the public health workforce, and the health workforce, I think there's a lot of space in there, and that will also drive transformation. Support for civil society actors and social movements to really deepen that accountability for more inclusive health systems and work. And finally, innovation. I mean, the last year has told us that when we come together and really work and try to work and innovate, we can do pretty amazing things. Imagine if we harness that power of innovation for gender transformation, for equality. I think it could be pretty powerful. So again, I'm ultimately an optimist. And so I think those are 6 areas where I'd love to see sort of donors align and really come into this agenda.
Thank you, Catherine. Well, you ended off with innovation and you began with transformation within ourselves. I think that moves us brilliantly onto Professor Kent Buse, who co-leads the GH5050 Collective. And as we heard earlier, is the director of Healthier Societies at the George Institute for Global Health. Kent, do we need the shift to discourse to advance the gender and health agenda? And I'm also going to push you a little bit further on this. How do you convince men, specifically men in power, men like yourselves, you have important roles at decision-making, at policy level, you with UNAIDS for many, many years in your career, that this really matters? How do you convince them that you're all stakeholders, as Ravi said as well?
Well, thanks, James. And we've spoken about this before. And, quite frankly, Global Health 50/50 has its own gender problem. And we see that around 90% of the volunteers that sign up are in fact women. So I want to thank James and Ravi, both of you, for joining our advisory committee and stepping up yourselves. And of course, volunteers are early career women for the most part, who undertake the bulk of the unpaid childcare, healthcare, elder care, unpaid care of all kinds. And we seem to have this sort of really bizarre notion in global health that gender is a woman's business. And I think on the one hand, that's because some men unfortunately think that they might lose out from gender equality. And I find that both sad and infuriating, really, that by perpetuating these gender norms, we've seen the data that Sarah's presented demonstrates that men also lose out from gender inequality. And it's a more complicated and I think nuanced conversation, but some of the data suggests the more gender equality we have, the more risks that women will face because of the kind of work they do or the kind of stress they're under and so on. And that in fact, it is very much, as this panel has said, it's a matter of equity and social justice, and that we should link the gender equality struggle to those. I do think that we need to change the notion from that sort of zero-sum game mentality to a very different kind of mentality. And again, I think the panel has been there, that everyone can, everybody should, and everybody will benefit from gender equality. And I think that men should join the good feminists and to fight to change the system. And we heard from the panelists that it's a political issue. It's an issue of power, and ultimately it's a matter of changing systems. And we need to start at the top. And I don't know if you saw in our report this year, we had something called an empty word. In previous reports, we had the likes of Prime Minister Jacinda Ardern, Amina Mohammed, and other feminist women leaders provide a forward. This year, as a reflection of our concern for gender equality, we invited a number of senior men to join Kamsal Bayezid to also offer a forward, and we didn't have any men that came forward. So I want to say, James, that discourse is good, but it's just a start. And you know that Global Health 50/50, our tagline is to inform, inspire, and incite. Our report hopefully informs. Our report hopefully inspires, and we have Catherine here and Anuradha, both showing examples of good performance, but also Catherine, I think, wanting to take the Gates Foundation a bit further. But I think we as feminists in the global health community must do a lot more to incite. And I think that, it behooves us really to support people in that context of equity that Anuradha was speaking about, to help people to organize and mobilize from below to demand change. Power, as I think one of you said, isn't easily given up. We need to demand that. And please join us at Global Health 50/50 to bring that about in this sector. James, thanks.
Thank you very much, Kent. Anuradha, can I just give it to you for our last 60 seconds? We live in troubled times, and we live really in a week where someone has brought up the issues of race and identity politics all over again, from the top right down to the bottom and everyone in the middle. As someone who has seen so much and as someone who's experienced so much, Anuradha, what do you compel us all to do?
Yeah, so based on this discussion, I was listening to Kent, and I started to reflect on this. Two things from my side. One is that I think gender balance is essential for change. You know, if we really want to see change, we'll have to make sure that we have a balanced representation in our governance, management, senior leadership structures. And this is what we have done at Gavi, and we have seen the results of that, because now we have such a strong commitment to change, to equity, to gender in the new strategy that we are embarking on. And the second is that gender and equity are highly intertwined. And I think it's also important for us to realize that. And for that, you know, I think the first is really this whole discourse and commitment. Second is to translate that into a concrete strategy like we did. Third is putting dedicated financing behind that. So now we actually, our board approved $500 million, you know, as dedicated financing for just equity, and gender is such a big part of that. Actually, gender is the central piece. And what then it is doing is to actually trigger that conversation with countries about who are the people who are being left behind, who are the children who we are not able to reach. And the moment we start to dissect that, we realize it is gender-related barriers, you know, that are playing such a big role. And then trying to understand those barriers and responding to them through certain programmatic interventions. For example, you know, a simple thing like changing the time of the immunization session to late evening, you know, made so much of difference to those poor women who could not afford to forego their daily wage, you know, and bring their child to an immunization session that was happening in the middle of the day, right? So but to a more gender transformative approach. For example, in some countries, we started to bring men into the conversation and started to work with fathers to also shoulder the burden of child rearing, you know, and also bringing the child for immunization services. So I think there is a spectrum here, and we have to start to sort of think about the low-hanging fruit, like, you know, just changing the timing of session or changing the location, which is more convenient to women, to more complex interventions, which then start to speak to some of the power structures and imbalances that we talked about.
Thank you very much to Anuradha Gupta, to Ravi Verma, to Catherine Hay, and very, very much so to the two people who helped all of it happen, Professor Sarah Hawkes and Professor Kent Hughes, and they will never forget me if I did not mention the entire G8 50/50 collective, particularly the young people like Sonia Tanaka, Anna Purdy, and Imogen Bakalum, who do this work day in, day out on their skilled level, and many, many more besides. So I've done that for you, Sarah and Kent, but I must also say this. Please follow the beautiful photographic essay that is being published by the Guardian newspaper, that for a second year, GH5050 brought in photographers from all around the world. There was supposed to be a massive exhibition at UCL last year that just got squeezed out by COVID-19 at that time. But you can see it all in the Guardian for a second year running just by Googling GH5050. YouTube, I think that this live stream will be available for replay later. Please share it for people who are not able to join, whether it be due to time zone or otherwise. And then follow us on social media and tweet hashtag flying blind and hashtag GH5050, which is the one that we use throughout the year. I'm James Chow. Thank you very much for being with us. Take care of yourself and take care of the strangers around you as well. Goodbye.
Thank you.